So maybe I'll just start with, before we start the talk, I would say I have 3 Herculean tasks to be done. One is finishing 2 very important topics within a span of 20 to 25 minutes. I'll try my best. Keeping all of you awake after a very wholesome lunch again is going to be a tough job, but I'll try. And my co-speaker, Ajay Oswal sir, who is a perfectionist matching to his expectations. All 3 Herculean tasks given to me, but I'll try my level best. Perfectionist matching to his expectations. All 3 Herculean tasks given to me, but I'll try my level best to do justice to it. So basically we will first start with role of Doppler in AV fistula assessment. As we all know, fistula is a lifeline for CKD patients, and it is an abnormal surgically created communication between artery and vein. How we as radiologists can help is for pre-op vascular mapping, post-op assessment of fistula maturation, monitoring or routine surveillance, and early detection of complications. You all know these 3 are the commonest type of fistulas, and amongst these 3, the commonest one is radiocephalic, followed by brachiocephalic or brachiobasilic, only done when these 2 are not possible, because that is a 2-step procedure. The non-dominant arm is the one which is preferred, supine position, and importantly you need to tie a tourniquet above the elbow level. So artery and veins both are mapped after the tourniquet is tied. Preoperative arterial mapping should start from the axillary level up to the radial and NR, but practically we usually start it at the level of the brachial. Importantly, only not mentioning about vessel diameter, it is important to mention about the wall morphology, any area of stenosis or occlusion, and assessment of blood flow. Each one of it carries its own importance, so mentioning about all these is very, very important. Vessel diameter has to be taken in a transverse section of the artery. Mentioning about the wall calcifications, again very important, because a surgeon finds it tough to anastomose with a vessel which has a calcified wall. Also, arteries which have a bad wall morphology do not support fistula as for the blood supply. So it is important to mention whether the artery is healthy or it is calcified. Blood flow assessment of the artery is again very important, because fistula being a high flow rate, the artery has to supply a lot of blood to the fistula post maturation. So the artery should, at least the radial artery, brachial doesn't matter, but when you're seeing the radial or planning for a radial fistula, seeing the arterial flow at least more than 50 ml per minute is very important. Only then there is a chance that the fistula matures well. This is how you can depict your arteries. You can show the brachial artery diameter, the radial and the ulnar artery diameters, and the depth from the skin surface. Other important thing is hyperemia response. This has to be seen. This is when the fist is closed, the radial artery has to have a very high resistance triphasic spectral Doppler pattern. When you clench the fist for about 2 to 3 minutes and then release it, there should be a lot of vasodilatation. This is important because this is the artery which has to dilate or has to supply the fistula. So only if there is a good hyperemic response, this artery is going to supply a lot of blood to the fistula. After the arterial evaluation is done, we now come to the venous. Venous, you know that we use the superficial veins of the arm for fistula formation. Basically, it is the cephalic vein which is utilized. The cephalic vein drains the lateral aspect of the limb, while the basilic vein drains the medial aspect. But the basilic being deeper, it is the cephalic which is being preferred. What do you see when you are assessing the vein? The vein should have thin regular walls. What happens in CKD patients is, because of repeated blood sampling and repeated IVs which are being given to these patients, these do develop chronic thrombosis. So mentioning about the wall, they are completely compressible, that is no signs of any thrombus. Course of the vein, because they are going to utilize the vein for fistula formation, they should have at least 8 to 10 centimeter of vein which is sufficiently linear. It should not lie more than 6 millimeter depth, because again a lot of superficialization needs to be done if the depth of the vein is more, and there should be no accessory vein within 5 centimeters of the fistula site. So vein diameter criteria is again very important. The diameter of the vein should be measured again in a transverse plane only. There are multiple studies which mention about different sizes of the veins, but in general a 2.5 millimeters of vein at the wrist should be at least documented, or should be 2.5 millimeter vein is desirable when you plan a fistula. Again, this is how you can document the entire venous anatomy, the diameters of the vein and the depth from the skin surface. Importantly, about any thrombosis, vein walls, they are regular. The length of the vein, that there is no tortuosity, because if there is a lot of tortuosity, again it becomes tough for the surgeon for fistula formation. Very importantly, one thing which we need to see is central venous occlusion. CKD patients usually have central venous catheters put in, and if there is a central venous occlusion on the ipsilateral side where the surgeon is planning, that patient, because of high flow within the fistula, is going to land up with limb edema. So before we are suggesting them that yes, this side for the fistula is good enough, we need to see for the deep veins, the central veins. Basically, we cannot insunate our probe for seeing the subclavian vein, but how do we indirect sign is when you're seeing the IJV, when you're tilting your probe and seeing the proximal most portion of the IJV, you should see good amount of pulsatile flow. That is because the IJV is going to give you an idea about the right heart. So there should be a lot of pulsatile flow. If there is a monophasic flow in the IJV, we need to document this, that this limb needs to be avoided, or a central venous occlusion is present on this side. So before planning a surgery, the urologist needs to know that some type of central venous occlusion is present, and he needs to take care before the fistula is being formed. Very important, this is the crux of all this pre-op fistula evaluation. Peripheral arteries diameter at least 2 millimeter. Hyperemic response should be there. Patent palmar arch, because if you're using the radial artery, the radial is completely going to supply the fistula. So the ulnar artery should be good enough quality that it will supply the palmar vessels. Peripheral veins, with tourniquet, it is only done with tourniquet. So it is the diameter of the peripheral veins need to be more than 2.5 millimeters, and central venous patency needs to be mentioned. So this is how we report. Your report should have all the diameters, whether it is a healthy vessel, any atherosclerosis present, and distance of the artery and vein, distance from the skin surface, and whether there is any central occlusion present. So a fistula is done. When the patient comes for a post-op evaluation, according to the National Kidney Foundation, rule of 6 needs to be followed. But usually as a radiologist, or even in general practice, we follow the rule of 5, where the vein should be at least 5 to 6 millimeters in diameter. It should be within a span of 5 to 6 millimeters from the skin surface, and the flow rate of the fistula should be at least above 500 ml per minute. So these need to be satisfied for the fistula to be functional. So when the patient comes for a routine follow-up, what we need to evaluate is the feeding artery. As we come ahead in the description, we will see that the feeding artery, usually the radial or the brachial artery, shows a triphasic spectral Doppler pattern. But once a fistula is formed, you will see the feeding artery will show a monophasic flow with a large diastolic component, because this is the artery which is now supplying the fistula. You need to evaluate the site of anastomosis, the draining vein, and the volume flow of the fistula. So post-fistula Doppler report needs to mention all this, that the feeding artery is showing a volume of this much, the site of anastomosis is patent or whatever, thrombosed or stenotic, whatever it is, the draining vein, what amount of flow it is showing, and the volume flow of the fistula. So this is how I told you that brachial artery routinely shows a triphasic spectral Doppler pattern. But here, after a brachiocephalic fistula, we see the brachial artery is showing a low resistance type of flow with a lot of diastolic component. That means that it has now matured and is supplying the fistula. Again, how the cephalic vein, it has dilated and at a distance of 5.9 millimeters from the skin surface. So these all criteria for a fistula to be called mature. All these are criteria. You need to mention about the vein diameter, the depth from the skin surface, and whether this vein is showing arterialized flow. What we expect in a cephalic vein is just a monophasic or a biphasic flow. Here you see the vein is showing an arterialized flow. So all these points would take about 2 months to develop, and when the patient comes to us for evaluation whether the fistula is mature or not, we need to see all these points. Immature fistulas are basically which fail to develop, and there are multiple reasons why they do not develop, and that is the reason they are sent back. Usually for maturation, urologists or the nephrologists do not send it back to us because they clinically see the thrill. If the thrill is there and they are able to cannulate the fistula, they do not send it to us. But in case they are not able to feel the thrill or their technician is unable to cannulate the vein, they send it back thinking that whether the fistula is mature or not. So when the patient comes back to us for evaluation of the maturity of the fistula, there are multiple causes which could cause, or what are the findings when it is non-mature? The vein is small, so it is not going to give that amount of flow. The vein is too deep to cannulate, so they are unable to pass the catheter into it, and or the fistula is a low volume. Here you see it is just 96 ml per minute. So either of these situations, the fistula is immature, and what is important is if we are able to identify the cause, we can the surgeon can actually take steps to make the fistula functioning. So identifying the cause why the fistula did not mature is very, very important. There are causes of non-maturation. First important one is there could be stenosis at the site of the fistula. There could be one or more accessory draining vein or a deep draining vein. So in either of this situation, if you could identify, the surgeon could actually go ahead and make the fistula, convert it into a functioning fistula. Stenosis in AV fistula is very common, and it is because of intimal or fibromuscular hyperplasia which occurs. It could be at the level of the feeding artery, at the site of anastomosis, the draining veins or the central veins. We need to identify which of these is the culprit. What is the criteria for significant stenosis? More than 50% area reduction. Aliasing, as anywhere else in the body, any stenotic area will show aliasing at the site of stenosis, and a high peak systolic velocity at the site of stenosis, which is more than 500 centimeter per second. Here you can see a dilated cephalic vein, and at the site of the fistula, there is narrowing at the site of the fistula, and if you see the PSVs, they are very high in range of 843. So mentioning that yes, there is a stenosis at the site of the fistula will help the surgeon to go ahead and plan a fistuloplasty. But again, in this situation, we need to mention but the other things, that the vein has developed well and the vein is cannulable, that is the depth from the skin surface is normal. So if all other things are normal and only stenosis is the cause of immaturation of the fistula, they can go ahead and plan a fistuloplasty. Central venous occlusion, as I said, this was a working brachiocephalic fistula, but the patient presented with a swelling of that limb. You see that the fistula is normal, but it's showing a very hyper-functioning type of fistula, flow rate of about 1100 ml per minute and a lot of subcutaneous edema. So here, because of the subcutaneous edema, and you can see that there is some scar in the neck. That means she had a long dwelling central venous catheter. So this prompted us to tell that, yeah, probably this is a central venous thrombosis because the fistula was normal here. So here we are able to see that the angio showed that there is you can just see a part of the left innominate. We are unable to see the entire innominate. And this is post-plasty. Again, you can see after post-plasty, the entire brachiocephalic vein was seen well. So identifying, and this is post-procedure, the edema has really come down. So other important thing is for Doppler is early detection of complications. Again, because AV fistulas are superficial, they are very accessible by Doppler, and hence it is important that we identify. Not only identifying, but it also helps in guiding the surgeon about the curative procedure, what can be done. So these are the commonest types of complications of AV fistula we come across: stenosis, thrombosis, occlusion, pseudoaneurysm, true aneurysm formation, hematoma, perianastomotic leak, site collection, seromas. All these are common. Stenosis, we have seen one of the commonest complication of AV fistula is thrombosis. Thrombosis usually is located at the site of anastomosis, or it can be at the venous side or the arterial side. Again, mentioning the extent of thrombosis, the age of the thrombus and the site of the thrombus is very, very important. Here we see that the artery is fine, but the cephalic vein is showing a mixed echogenicity thrombus. Again, here the artery is fine. The fistula site is also patent, but the cephalic vein beyond the site of the fistula is revealing a mixed echogenicity thrombus. Again, acute thrombosis needs to be picked up because USG guided thrombolysis has wonderful effects, so has wonderful results. So if we are able to pick up fistula at a very early stage, that is when it is acute, again USG guided thrombolysis is going to help the patient. Pseudoaneurysms, like anywhere else in the body, true or pseudo, true aneurysms or pseudoaneurysms. True aneurysms, when there is complete dilatation of the draining vein. Here you can see that the vein, because of repeated needling, there is multiple punctures in the vein and this vein gets dilated. The diameter of the vein is almost about 13 millimeters, showing a lot of turbulence. So this is aneurysmal dilatation of the draining vein. Pseudoaneurysms, we need to identify this female with a long-standing fistula, came with a focal swelling at the site of anastomosis. And when we did a Doppler, this is showing the artery with the draining vein with a lot of focal dilatation, and this entirely was a vascular lesion. So this is a pseudoaneurysm formation. Again, when you are mentioning about pseudoaneurysms, it is important to mention presence of thrombus, whether there is any presence of thrombus in the wall. Because if they are very thin, large, without presence of thrombus, they are susceptible to rupture. So mentioning about the wall, the neck and the presence of thrombus is important. Hematomas can be found. So this was a patient with a working fistula and he presented with a swelling, and when we did our Doppler we found just a small collection. So these need not be actually small collections, they usually resolve by their own, but if they are very large and causing compression over the site of the fistula, yes, we need to go ahead and aspirate them. Again, a hematoma, a patient with working fistula had a fall, and this is a large hematoma. Arterial steal syndrome, yes, this is why we said we need to check for the Allen's test, because if the radial artery is going to completely supply the fistula, and if the ulnar artery doesn't take up, then the patient is going to have peripheral signs of less blood supply, and that is the reason, that is where we need to again do a Doppler to see whether the ulnar is able to supply the palm or not. So Doppler ultrasound plays an important role in pre-op mapping, post-op maturation assessment, routine surveillance and early detection of post-AVF complications. It should be interpreted in conjunction with clinical findings. Results should be discussed in a multidisciplinary approach. We have been seeing it since morning. You should call up your urologist or your nephrologist and discuss with them, because functioning AV fistula is a lifeline for CKD patients, and we as a team should try to preserve each and every fistula. I immediately, we will start to our next talk, that is a practical approach to transplant kidney Doppler, and then we have a discussion of both the topics after this. So anatomy, I think we know that it is placed in the RIF extraperitoneally. The artery, the transplant kidney artery is anastomosed to the external iliac artery, and the transplant renal vein is anastomosed to the external iliac vein. The ureter by a neocystoureterostomy is communicating with the bladder. So whenever a patient comes for a transplant Doppler, what are the parameters we need to check? We need to see for the main renal artery, PSV and RI, the site of anastomosis, the feeding iliac artery, the patent main renal vein and iliac vein, perfusion of the graft, RI in the segmental arteries of all the poles, and again, importantly, please have a look at the native kidneys, because patient comes with UTI or comes with pain, and again what we usually see is just the transplant Doppler, but then we forget to see the native kidneys. The culprit is the native kidney, probably that is the one which got infected, but we haven't seen it. So also have a look, even if the patient has come for a transplant kidney Doppler, have a look at the native kidneys. So the kidney, because it is very superficial, you are able to see it well. It picks up color very, very nicely. So measuring the length of the kidney, mentioning about the ecotexture and the color flow in the kidney. Site of anastomosis, again important. This is the site of arterial anastomosis, site of venous anastomosis, seeing the site whether there is any stenosis. at the site of anastomosis is important. This is the main renal artery flow. Mention about the PSV in the main renal artery. See for the main renal vein, the interlobar arteries flow. So mentioning all this is important. Usually transplant kidney artery, the intrarenal flow, they initially used to see a PSV, the RI of 0.7, but 0.7 to 0.8. These RIs are acceptable in a transplant kidney Doppler. The complications which we come across in renal transplant, we can categorize them depending on the time frame they present or the area of the kidney or the site what they are actually affecting. It could be either the perinephric space or the renal parenchymal abnormalities, urinary collecting system or renal vasculature. Depending on the time frame, acute, which is the commonest ones are the renal artery thrombosis, renal vein thrombosis, perigraft hematomas. Subacute presentations, ATN rejection, external compression or AV fistula, which is usually iatrogenic after a biopsy is done, and chronic, that is renal artery stenosis. So perinephric space collections usually seen about 50% transplant patients. They may contain urine, blood, lymph or pus. I would suggest we should not go ahead and mention it as a seroma or a lymph only hematomas we can actually say they are hematomas depending on the echogenicity. We know blood looks hyperechoic, and as it stages, the echogenicity of the blood will change. So blood, yes, we can mention. Important is to mention the site and whether it is causing any mass effect, whether it is causing any compression over the renal hilum and the ureter. So importantly, it is the presence of a collection which is causing any mass effect on the transplant kidney, ureter or any other adjacent structures. This is important. Renal parenchymal abnormalities, again, all will present with a bulky kidney, increased echogenicity and raised RI. So we cannot differentiate ATN from drug toxicity or acute or chronic rejection. What we can mention is there is altered echogenicity and raised RI. This diagnosis is going to be a biopsy diagnosis. So we could just say, yes, there is increased echogenicity, the renal artery and the vein is patent, there is altered echogenicity, and we need to go ahead with a biopsy to diagnose what exactly is going on. Renal vasculature abnormalities, renal artery thrombosis and renal vein thrombosis, again are early type of complications. Renal artery stenosis, renal vein stenosis, they present late. Arteriovenous fistulas and pseudoaneurysms are probably iatrogenic because of the percutaneous biopsies which we do in transplant kidney. So this is how the time frame goes. Usually when a KT is going on in your own hospital, you get a call from the surgeon that you need to come in the OT. So in an OT, when you are called for a transplant kidney Doppler, the information what the surgeon requires from you is whether there is a good graft perfusion, that is the renal artery and vein are patent or not. And other important thing what we need to see is hematoma. Mentioning about the PSVs in OT or in an acute setting is not very important. Whether the graft is perfused and whether there is any hematoma. Usually subcapsular hematomas are the one which cause a lot of compression and a deranged renal function. So you need to mention this. So this is a renal artery thrombosis. Here if you see, again this video probably won't play. Okay. If you see, the artery is appearing mildly bulky and there is no flow whatsoever. A transplant kidney is placed superficially. So even if you are not using a power Doppler, even your routine color Doppler is going to pick up a good color. So if there is no color pickup in the renal artery, and we tried on a power Doppler as well, it was showing no color pickup. That was a complete thrombosis. That was a complete renal artery thrombosis. This is a segmental renal artery thrombosis, a wedge-shaped area. The other parts of the kidney are showing color pickup, but when we are putting a color box over this area, there is no color pickup in this area. This was a segmental renal infarct. Usually that is not very important, but picking up acute renal artery thrombosis is very important because this is a salvageable condition. If we pick up early renal artery thrombosis, they can get the patient back to OT, redo the arteriotomy. They can do arteriotomy, thrombolysis, or they can actually do a thrombolysis, and this gets the kidney back into perfusion. So renal artery thrombosis can be a presentation of acute and hyperacute rejection. There could be underlying hypercoagulable states, arterial kinks, dissections. There could be a vessel size mismatch or a faulty surgical technique. So this is not what we need to see, but what we need to comment is there is no flow within the renal artery and the renal parenchyma, and this is very important because this is going to salvage the kidney. Renal vein thrombosis, again a very dreaded complication. We need to pick it up because if picked up in early stages, again the graft is going to be salvageable. Here you see that the renal vein is showing a mixed, I'm sorry for the images, all these are done on bedside Dopplers. These are all bedside, not done on our routine machines. So the quality of the images is going to make a lot of difference. These are the renal vein is showing an echogenic thrombus, and the intra-arterial flow, pulsatile flow in the intrarenal vessel is one of the diagnostic for renal vein thrombosis. You could get a high resistance flow in renal parenchymal abnormalities, but a pulsatile flow in the renal vein, in the intrarenal pulsatile flow, or the main renal artery also showing a pulsatile flow with no flow in the renal vein, we need to seriously think about renal vein thrombosis and convey it to the urologist. Renal vein thrombosis, again patient presence, the typical presentation is acute pain, swelling, tenderness over the graft. It could be because of compression of the renal vein by a fluid collection or hypovolemia, again underlying hypercoagulable states or a poor surgical technique, but picking up a renal vein thrombosis is going to help save the transplant. So as I said, elevated intrarenal RI, there is a huge list of things which could present with raised intrarenal RI, including renal vein obstruction. But when in raised intrarenal RI with no flow in the renal vein is renal vein thrombosis. But if there is elevated intrarenal RI, these things need to be sought for, and this subset of situation we are not able to diagnose on ultrasound, and we need to suggest a biopsy. Renal vein, yes, we can pick up, and extrinsic fluid collections, obviously we can make it out on ultrasound. So as I said, these functional complications, that is ATN drug toxicity, rejection, all of them present with altered echogenicity, the kidney appearing bulky and edematous, and a raised intrarenal RI. For all these things, we would require a biopsy. Again, if it is drug toxicity, biopsy with a drug level will help you will help the surgeon to come to a diagnosis. Perigraft hematomas, this is from the OT. I think Chinchole sir and Sir Abhay Mahajan sir were there when we did this case. We were called in the OT, and there was a big subcapsular hematoma. They had just closed it, and there was a huge subcapsular hematoma. What we saw was a little bit of arterial flow, which was a very high resistance type of flow. They drained the hematoma, and immediately the flow came back to normal. So high resistance flow, but the venous flow is patent. That means it is not renal vein thrombosis. This was a perigraft, a subcapsular hematoma, which was causing a lot of compression over the kidney. And the moment, this is a different case. This is again, here you see the kidney is pushed up. There's a huge hematoma here. And when this hematoma was evacuated, the flow has come back to normal. So this is how important it is to identify acute hematomas, because they are very isoechoic to the kidney, are difficult to pick up. But then the double contour sign helps you in seeing that yes, this is outside the renal parenchyma. So this is a subcapsular hematoma. Renal artery stenosis is a late complication. Strictures can affect the iliac artery just proximal to the anastomotic site, at the site of anastomosis, or the proximal renal artery. When should you think, or the suspicion of renal artery stenosis occurs when there is severe hypertension which is refractory to medical therapy, or hypertension combined with an audible bruit, or hypertension associated with unexplained graft. A huge degree of suspicion, a high degree of suspicion is required, or else we are going to miss renal artery stenosis. A very high PSV in the main renal artery, a tardus parvus flow, as we see in other renal Dopplers, a high PSV at the level of stenosis, a tardus parvus flow within the intrarenal vein. And other important thing is, here this is just post-plasty, a patient with renal artery stenosis, you see a high PSV, a very low tardus parvus flow, and post-plasty this patient, the flow came back to normal, and the creatinine came back to normal. So it is very important to pick up these signs. Other very important thing we need to see is the PSV ratio, what most of us do not see, the PSV ratio of the main renal artery versus the iliac artery, if this ratio is more than 3:1, that is one point where it clearly indicates that yes, we are dealing with renal artery stenosis, because in usual, the renal arteries being a bit tortuous do show a high PSV, that is PSV. So just PSV values more than 250 are not going to help. Velocities more than 300 centimeter per second, and if the clinically also the patient fits into high risk category, and if the PSV ratios of the main renal artery and the iliac artery are more than 3:1, you should think of renal artery stenosis. Urinary obstructions, we need to differentiate between physiological and obstructions which are pathological. Physiological, because of denervation, the urinary collecting system is flaccid, and so you can see some amount of hydronephrosis in transplant kidneys. But if this is, the other important thing is also see for a very distended bladder. Because the ureter is short, a very distended bladder is going to give you hydronephrosis in the transplant kidney. So these two important things are physiological hydronephrosis. Pathological hydronephrosis early usually occurs immediate post-op. That could be due to edema or blood clots at the vesico-ureteric junction. Late presentation could be distal stenosis or external compression by fluid collections. Urine leak, again common at ureterovesical junction, usually patient presents immediate post-op with a lot of drain, and this drain, if you do a creatinine, the drain shows a very high level of creatinine, which suggests yes, this is urine, so this is urine leak. Again, a repeat or a redo surgery is necessary in such cases. So this is hydronephrosis. Here we trace the ureter into the bladder, and you see that there is some amount of narrowing at the vesico-ureteric junction. A DJ stenting was done for this patient and the creatinine came back to normal. So identifying whether this is pathological hydronephrosis and does the patient need any surgical reintervention is important. Again, here the patient presented with hydronephrosis. You see these two large collections around the hilum. It is compressing the renal hilum and the ureter, and that is the reason it presented with hydronephrosis. So mentioning these two collections, and if possible we could drain it USG guided. So this is the importance of how we can help the patient in case the creatinine is getting deranged because of obstruction or hydronephrosis. Just a word about pre-transplant workup. Again, very important, when we are doing pre-transplant workup, donor kidneys, we need to see the donor kidneys, whether there is presence of any cyst, any calculi within the kidney or any masses. So mentioning all this is important. Analysis of the recipient, whenever a patient comes to us for pre-op workup as a renal transplant recipient, please check his iliac arteries, whether the iliac arteries are showing any calcifications. They anyways get a CT done. So CT is going to pick up, but on ultrasound what we need to mention is the presence of calcifications, because if this is the case, the surgeon needs to know that yes, he needs to know that there's a lot of calcification within the iliac artery, which is going to use for anastomosis. So in a nutshell, ultrasound plays an important role in diagnosing and monitoring renal transplant complications. Grayscale helps us in identification of mass lesions, hydronephrosis, perigraft collection. Doppler aids in detecting arterial venous thrombosis, tumor vascularities. Several limitations to ultrasound, including as assessment of renal function or to differentiate between various parenchymal abnormalities. So we need to accept that yeah, these are our limitations, and we need to have a word with the urologist or the nephrologist that biopsy is going to help us in these conditions. So I have a few questions. Let us see, because all of you must be sleeping probably. A very high resistance waveform with diastolic reversal in the renal artery indicates aneurysm, chronic rejection, RVT, or renal artery stenosis. Reversal of flow in the renal artery, renal vein thrombosis, yes. Aneurysm is not going to present as aneurysm, we know, will show a very pulsatile or yin-yang flow within it. Chronic rejection is not going to show you any reversal of flow. It might show you a high resistance flow, but the renal echogenicity, the size is going to help you. Renal vein thrombosis, as we said, is going to present as pulsatile flow or reversed flow within the renal artery. An elevated RI in the transplant kidney indicates AV fistula, renal infarct, non-specific graft dysfunction, or renal artery stenosis. Non-specific graft dysfunction, yes, we need to go ahead with a biopsy because differentiating amongst the non-specific renal graft dysfunction causes like ATN or rejection is not possible. So anything which is showing an altered echogenicity with a high resistance flow within the transplant kidney, do think of non-specific graft dysfunction. Patient with a brachiobasilic fistula, swelling along the draining vein. Diagnosis. This is a flow, this is a swelling, this is the site of fistula, and we have placed the spectral Doppler at the neck of the pseudoaneurysm. Yes, so thank you very much for a very patient hearing. I'm sorry for being very fast.
Thank you, ma'am, for giving such a wonderful presentation. Next, I would call upon to the dais Dr. Ajay Oswal sir for the presentation.
So whenever I go to Dr. Thomas' cabin for seeing any transplant Doppler, he always I keep on demanding more and more information, and he always says one sentence, always, आपको भगवान महावीर भी satisfy नहीं कर सकते. But today I must say that Dr. Sonali had covered everything that is required for AV fistula and transplant. I must congratulate her for her experience and presentation. So there is one movie called Bas Itna Sa Khwab Hai. The tagline of that movie was, all I want is everything. So urologists are greedy people, they want everything. So Dr. Sonali has given us everything in fistula and transplant. So I won't go into many details because of shortage of time. So what urologists want, we are complication prone surgeons. So we want a roadmap ahead, what lies ahead for this patient's upcoming surgery. And when we have done the surgery, we want a rear view mirror from you to tell us what mistakes we have done. So for AV fistula pre-op preparation, Doppler is essential, and we expect, what we expect from a radiologist is a colorful diagram or a black and white diagram, as Dr. Sonali had showed, a vascular map, which vein is coming from where and how many tributaries and the condition of the artery, vein, and of course if you can give us information about central vein, that is very important, because whatever be the quality of AV fistula constructed, if central vein is occluded, that patient's fistula is never going to be useful. It will end up in a swollen limb. So anyone can say that this is a pseudoaneurysm 2 weeks post AV fistula creation, but only Aniruddha could tell me few additional points in this Doppler. This is a pseudoaneurysm. You can see that this is yin-yang flow of pseudoaneurysm of a brachiocephalic AV fistula, but the additional information provided was this stenosis of the draining vein. So this is additional information, bonus marks to Dr. Aniruddha. This is extra information given, and that makes my life easier, and this is what I request for. In transplant evaluation, the vessels which we are usually looking at is external iliac artery, internal iliac artery, and external iliac vein. So we need from a radiologist the quality of those vessels, whether there is thrombophlebitis or not, whether there is any perivascular fibrosis or not, and the condition of the arterial wall, mainly atherosclerotic plaques and calcifications. Of course, you can do a CT, but if you can give us information on Doppler, it's most welcome, because that is going to affect the quality of my surgery and the surgical outcome. So this is internal iliac artery to renal artery anastomosis, and renal veins, there were 2 veins, anastomose to the external iliac vein. So post-operatively, if you are aware of this, my intraoperative findings and diagram, you will be able to give me a better information about the status of the anastomosed vessel. Sometimes, or many a times, the quality of machine and quality of the radiologist becomes suddenly more important in a given situation. This is high-end surgery, so I think, in my humble opinion, good quality machine is extremely important. It cannot be done on a simple or ordinary machine. Please do not misinterpret my statement. I had seen a case where the radiologist told me इस किडनी में फ्लो नहीं है, लेकिन क्यों नहीं है, he could not just show me. So I went into the radiology room. Since I am not licensed to hold that probe in that hospital, I held his elbow and told him, ab hila haath. So now see what I could find out. This is transplanted kidney, no flow. Okay, agreed. But why? So when I held his hand, this is what I could see. So this is the pseudoaneurysm at the anastomotic site of internal iliac artery. So this makes the difference, machine and the man. Similarly, in that picture, 45 minutes were spent. We did a Doppler because creatinine was not coming down as expected. So we had to go to the Doppler room and we had to inform the radiologist. She had not cared to read those notes, but we had to inform her. There were 3 arteries, right kidney had been retrieved, and we had anastomosed these 3 arteries at these 3 sites, and now show us the Doppler. So if you see the lower pole is clearly unperfused. So that is, there is some complication in that artery, and from our notes we gathered that the lower polar artery had been anastomosed to the inferior epigastric artery. So immediate cath lab intervention could be done. So it is very important to pick up these intraoperative findings and report accordingly. That is what I request for. That is what a transplant surgeon requests for. Similarly, recently we had a brush with a disaster. This is a 12 years 20 kg child who had no other dialysis access. So he was being dialyzed through a femoral vein permacath. It is really a horrible thing to do, but that nephrologist or that child had probably no choice. So we were planning a transplant on left side. Therefore, in anticipation, we did Doppler of iliac vessels. Obviously, on right side there was the permacath, and on left side the external iliac vein had been reported as normal. So we opened the left iliac fossa and we had this finding. The vein that is looped there is not an external iliac vein, but it's a internal iliac vein which is distended hugely, and the vein which is held above the forceps is thrombosed cord-like external iliac vein. So this external iliac vein on preoperative Doppler had been reported as normal. Had I known this finding on Doppler, I would have opened some other site cranially, say orthotopic transplant or common or lumbar region transplant. So this was an intraoperative finding, and it really landed me in deep trouble like this. But because of that distended or dilated internal iliac vein, we anastomosed that internal iliac renal vein to the side of internal iliac vein, not to the always we anastomose the renal vein to external iliac vein. But in this child, since external iliac vein was thrombosed, the external iliac vein is beneath that transplant ureter seen on the left of that image, and the vessel in front of the forceps is the thrombosed external iliac vein, and the renal vein is anastomosed to this distended internal iliac vein. That's almost unheard of, very unusual. But we had to innovate something on the table, and artery has been anastomosed to the external iliac artery. So you telling me something important, abnormality, is extremely important for my surgical outcome. In a nutshell, dear friends, it is always a collaboration between you and me, and I have always believed that urology is Uro Radiology. Thank you for your kind attention. We will be happy to answer your questions, please.
Has sir said, quality of the artery is very, very important, because just mentioning about the size is not going to be helpful. The quality of the artery, because that is the one which is going to supply the fistula. So quality of the artery is very important, a healthy artery for a working fistula. Sir, as you said, the case which was missed, I think probably yes, the radiologist needs to see, but sometimes in a
There is nothing personal.
No,
I am
no.
not naming the radiologist, and I am not complaining against any of my friends. We all make mistakes. We have also made mistakes, like our artery had ended up in a pseudo aneurysm. So we are not gods.
But we learn,
our
yes.
mistakes.
So that is how when a patient comes from for a transplant workup, we now need to see the external iliac, the internal iliac, and do make a note or a mention of the healthy arteries in our reports. So that can save us from such disasters.
That's the precise reason. Since morning we are here. What is the expectations of imaging person to give report, which will definitely benefit the urologist for taking decisions, number one, and eventually it is the patient who is going to get benefited out of it. So combined effort, as he has rightly stated, it's a collaborative effort from urology along with urology to come to a conclusive part. So I think that's very, very mandatory.
If you give me 2 minutes, I will narrate one incident. I will not name any patient, doctor or hospitals.
I can guess
Abhay and me had done a transplant at one center, and the creatinine was not dropping as expected. It was dropping, and the recipient was producing some amount of urine. So a Doppler had been ordered, and the radiologist said, "Iski artery gayi." So the nephrologist immediately called us and insisted upon re-exploration. So we told him that we are very confident of anastomosis, at least in this patient, because it had been a 3 mm punch hole in the external iliac artery, and a spatulated renal artery was anastomosed to that punch arteriotomy. And we are very confident. Either you do a angiography or you do a Doppler at some other center. So this patient was sent to some other center for EC scan in an ambulance, and taking that bahana, we asked another radiologist to see that EC scan and also do a Doppler. And he said, this recipient has anything but renal artery thrombosis. His kidney is very well perfused. Please find some other cause for acute allograft dysfunction. So this made a sea of difference. We had opened a patient giving GA and finding nothing, versus a good sonologist saved our skin as well as patient.
Yeah. See, post-operative Doppler, renal Doppler for transplanted kidney is really difficult procedure, because even though it is a retroperitoneal organ that we placed, the bowel immediately comes right in front of the vessels.
Air, bowel
And air,
immediate
yeah.
post-op air.
So,
lot
yeah,
of
so
air.
that is actually the radiologist should dedicate a lot of time and efforts to actually locate the arterial pattern where it is, and then only he will be able to diagnose properly.
And in that, the angle of inclination, where you hold the probe, the way you hold the probe, that technique has to be learnt and mastered.
Nice presentation, Ajay and Sonali. Thank you.
We are very proud that this presentation was absolutely flawless and more than expectations. It is because our center is one of the best center for transplant surgery in the India. And our radiologists are very much versatile doing all these things. Even yesterday, Dr. Oswal was appreciating radiologist for giving information for surgery. So what is important in Dr. Ajay Oswal say was कि roadmap is shown and rear view is shown to again select the roadmap by the radiologist, and the life is attached to radiologist, I mean surgeon's life, as much as GPS to the traveler. So I say, and with little more care, little more attention, little more confidence, everybody can become best. Thank you very much.
Thank you, chairpersons.